Well, hello everybody and welcome to our Meet the Experts webinar about thyroid and menopause. My name is Julia Priestley and I'm one of the joint CEOs at the British Thyroid Foundation. We've been running these online meetings for 3 years now, and it's no surprise that today we have our biggest audience yet. We all have so many questions about thyroid and menopause, which symptoms may be attributed to either of them, what impact the various treatments could have. And we're really looking forward to having some of our questions answered today. So I'm delighted to introduce you to Dr. Catherine Napier, who's kindly agreed to chair our meeting. She's a consultant endocrinologist at Newcastle on Tyne Hospital Trusts, and she has a particular interest in menopause herself. Catherine will introduce you to our fantastic speakers, and so please write your questions in the Q&A box, and as many as we can get through will be put to the speakers after their presentations. We've got a big audience tonight, so if we don't get round to your question, you can always contact the BTF after the event and we'll do our best to answer them for you. So over to you, Catherine. Thank you.
Thank you, Julia. It's my pleasure to be here this evening to chair this webinar on thyroid and menopause. We've brought together two expert speakers this evening. Professor Anise Mukherjee is a consultant physician, endocrinologist, and honorary professor. She has a wealth of experience in providing menopause care to women. She will provide an overview of her approach to the menopause. Following this, Professor Christine Bollaert, Professor of Endocrinology with special interests in thyroid and women's health, will share information on thyroid conditions in the context of perimenopause and menopause. After this, we'll open up for questions and answers, and we'll try and share as much information as possible. So please do submit your questions during the initial talks, and then we'll try and get as many of those answered as possible. I'll hand over now to Anise. Thank you.
Thank you, Catherine. Right, I'm just going to share my screen. Here we go. Okay, so I'm going to start with a general overview of menopause and symptom management. Then Christine will focus more on the thyroid side of menopause, but I think it's important to give you an overview of menopause in general initially. So the objectives of the next few minutes of me speaking will be to talk a little bit about why midlife and menopause are different for women today. I'm going to decode some of the menopause terminology and help you understand some of the symptoms, particularly in relation to the relevance of thyroid conditions and other health issues in midlife. And I'll do a quick guide to self-management strategies and treatment options before handing over to Christine. So I think it's important for us all to be aware, really, that women's health in midlife today is actually quite different from any other generation. Women's hormones in general have been shrouded in secrecy throughout time until very recently, with minimal information available to women, and I think it's fair to say very insufficient support. And you may think that's still the case, but things are changing and hopefully changing for the better, perhaps not as quickly as we would like, but things are changing. But certainly today, there are unprecedented challenges for all women in midlife. There are more demands, more pressure. There's more women working today than ever before. And because everybody's circumstances are different, every woman's experience going through the menopause transition is different. So understanding your own body and what's going on can definitely facilitate purposeful choices during the stages of the menopause transition. So raising awareness is really important. So I thought I'd just provide a few facts about the menopause transition, because we use these words a lot and sometimes we're not always sure exactly what all the words mean. So the perimenopause, and hopefully this audience, everyone will be aware, but I'll just quickly go through things. So the perimenopause is a phase of hormone changes and often hormone imbalances before your periods finally stop when you've actually gone through the menopause. And perimenopause can last from a few months to years. Periods can be regular or irregular. You may still be fertile and your tests may be normal. So we don't usually use tests to diagnose this phase. And some women have no symptoms during that phase, but symptoms can sometimes fluctuate, and they can get, you can go through phases of lots of symptoms and phases when there are no symptoms. And perimenopause is very common in women after the age of 45. Menopause is described as when your periods finally stop. And because in perimenopause, periods can become quite irregular, and you can have, hardly any periods, and then you can just have unexpected periods after a few months. We have to sort of make the diagnosis of menopause when you've had absolutely no periods for 12 consecutive months. So it's a retrospective diagnosis, and the average age in the UK is about 51, but 1% of women will go through menopause under the age of 40. And there is a link between premature ovarian insufficiency, that's that very early menopause, and thyroid conditions, which I'm sure Christine will talk about. And then postmenopause is all the time in your life after your periods stop. So let's talk about symptoms. Well, these are very common. About 70 to 80% of women will notice some symptoms, and those can occur in the perimenopause right the way through to the postmenopause. But for most women, actually, symptoms tightly linked with menopause are relatively mild. Up to 25% of women, though, will suffer with severe symptoms. And those women who suffer severe symptoms may well have other medical problems or hormone problems, including thyroid disease, that are impacting on their symptoms. But for the vast majority of women going through the menopause transition, symptoms gradually and spontaneously improve over time, usually over 2 to 10 years. And that's for the majority. There are a small number of women who continue to experience symptoms long term, though. So there is better support for women today, both in terms of menopause and managing symptoms, better than ever before. So if things are feeling like a struggle to you at the moment, rest assured you will get your life back on track, because symptoms usually settle spontaneously over time, and there are more treatments available than ever now. But when we're talking about symptoms, what are we talking about? What symptoms? And this is where things get quite complicated and are very relevant to the audience today. So when we talk about peri to post menopause, we often think about irregular periods. Periods can be heavier or lighter, more frequent or less frequent. So that's definitely a symptom that's associated with the menopause transition. But the other symptom that's very tightly linked with the menopause transition are what we call the vasomotor symptoms. So that's the hot sweats, flushes, flashes that we describe. And very many women experience those, but not every woman will experience those severely. And it's not a catastrophe if you do experience some of those symptoms, but it can feel very traumatic for the women who get the most severe symptoms. And then vaginal symptoms, so that can be a varying different symptoms, from dryness, soreness, pain, itching, through to recurrent water infections and other symptoms, and they're relatively common. But then there are other symptoms, and I put those in grey for a reason: sleep disturbance, fatigue, mood changes, anxiety, palpitations, overwhelm, joint pains, weight changes, weight gain in particular, and other body habitus changes. And I put them in grey because these are symptoms that are actually common across society, and they're not specific to the menopause transition. They can occur with other health issues, they can occur in men and younger women. So these symptoms are less tightly linked with menopause. And these non-specific symptoms are rising across society, and they are also symptoms you'll have worked out can overlap with thyroid conditions. And I think that it's relevant to mention here that a survey that was done by the Fawcett Society back in 2022 for Davina McCall's documentary in Channel 4, which surveyed over 4,000 women who were taking hormone replacement therapy, 54% of those women said hormone therapy resolved their symptoms, which demonstrates that 46% of women said that HRT hadn't resolved their symptoms. And that may be then because that 46% had other contributors to their symptoms, whether it be lifestyle, thyroid problems, or other health issues. So I think it's important, if symptoms aren't resolved, to look more widely for causes. So how do you navigate the menopause transition in today's world, in a nutshell? And are there things you can do to reduce the impact of your symptoms and improve your health and well-being for the long haul? And the answer is definitely yes. So I'm going to start with lifestyle, and I don't apologize for this, and anyone who follows me on social media will know that I'm very big on recommending lifestyle, not only to help with a burden of symptoms across midlife and the menopause transition, but also to help with long-term health. So things like building up and maintaining daily movement, physical activity. I don't like to use the word exercise because that's a trigger word for many women who have got aches and pains and fatigue, but building up in small steps can mean that ultimately you can start doing exercise, and that's always good for your health. Aiming for healthy nutrition and a healthy weight, reducing your intake of ultra processed foods and substituting those with the nice rainbow whole foods. Managing sleep, which is a problem for many people in today's world because of lots of non-menopause related factors that impact on sleep, and also stress. So applying things like self-care, having downtime, having real life social networks are really important for stress management, quality of sleep. And not smoking and limiting alcohol, because both smoking and alcohol are bad for menopause symptoms and for your overall health. And try, if you want to make changes, to make small gradual changes. I call it microdosing your health changes. Don't do binge diets or fad exercise regimens, because you'll do extreme changes. You won't be able to keep them up, and you'll be back to square one on a snakes and ladders board. Okay, so these strategies also reduce your risk of all chronic diseases, which lots of women worry about: heart disease, high blood pressure, cancer, osteoporosis, and dementia. So it's really important to be aware that those things which sound, not very important, movement, managing stress, self-care, they are really important to your health. So then we go to treatment support. And of course, if you're really stuck in a rut with exhaustion and not being able to exercise, often you need something to give you a crutch to help you make those changes. So let's start with the basics, the non-prescription approaches. So the evidence-based approaches that are non-prescription are generally cognitive behavioral therapy. That's the best non-prescription treatment. Cognitive behavioral therapy has good evidence for improving menopause symptoms across the board, and cognitive behavioral therapy for sleep is also really important. Many women going through the menopause transition struggle with sleep. So cognitive behavioral therapy is something you can talk to your doctor about if you want to try that. It's not a quick fix. It doesn't work super quickly, but it's a really helpful treatment when it's utilized. There are lots of complementary therapies and over-the-counter supplements that often women find helpful, but evidence is lacking. There's not really many trials that show that these are helpful. But if you really think about it, things like yoga, relaxation, acupuncture, other stress management techniques are going to reduce your stress, and they may help with your sleep, and they can help with menopause symptoms for some women, but not all women. So it's worth considering and trying them if you want to, but if they don't work, there's no point continuing. With over-the-counter treatments, and I'm trying to steer away from specifically talking about thyroid because I'm leaving that for the next talk, but always be careful about over-the-counter remedies, and seek advice from your doctor or pharmacist to see if any supplement you're considering might affect your thyroid condition or any thyroid treatment. And if you are going to take one single treatment to help with that's complementary or that's a supplement to help with your menopause, I would say take vitamin D. Vitamin D is not actually a vitamin, it's actually a hormone, and it's really important for bone health across the lifespan, and it helps you absorb calcium into your body, and it helps with bone health. And that leads me to my next slide, which is a slight digression from treatment options, but it's really important and I'm passionate about it. And it's a question that many women ask about when they're thinking about menopause, because lots of women fear having brittle bones as they get older, getting osteoporosis. And we know that 1 in 3 women and 1 in 5 men, in fact, will develop brittle bones and an osteoporotic fracture, usually at the end of their life or towards the end of their life because of frailty and weakness. And we know that there are things we can do ourselves every day throughout life to reduce that risk. So I will also say that your thyroid plays an important part in maintaining healthy bones, so it's vital to have your thyroid optimally treated. But other factors that can increase your risk of osteoporosis are lack of movement and exercise. I've already talked about that in the previous slide. Weight-bearing exercise throughout life is really, really important. A diet that's deficient in calcium throughout life, so red flags are if you have a vegan diet or a dairy-free diet, make sure you're optimizing your calcium intake, because sometimes those diets, if you're not adding calcium fortified foods, you can fall short of calcium. Vitamin D deficiency, smoking, excess alcohol, these are all risk factors for reducing your bone health and risk factors for bone loss throughout life. There are certain medications that can increase your risk of osteoporosis in the long term. Gut problems such as celiac disease and other malabsorption problems. A history of early menopause, premature menopause, which is why we encourage women who are having a very early menopause to take HRT at least until natural menopause age. And also a family history of osteoporosis might indicate that you might be at increased risk. These things are really important. And going back to the vitamin D, Public Health England does recommend that everyone over the age of 1 year take a vitamin D supplement at least from April to September. And if you have risk factors for bone loss, you might be recommended to take it all year round. So moving on to hormone replacement therapy, which is an important topic. We know that there's been a real increase in usage of hormone replacement therapy to help with menopause symptoms. And I think there's around 2 million women now in the UK on hormone replacement therapy. It's important for you to be aware that thyroid problems are not a contraindication to hormone replacement therapy, and that hormone replacement therapy is the first line medication to manage menopause symptoms. But it's not one thing. It comes in very many different forms and formulations, and the hormone replacement therapy regimen you might need in the perimenopause may well be different as you progress through the menopause transition to postmenopause. So it can be difficult to navigate HRT. It sounds easy, but it's not always a straightforward solution. There are many combinations, and what works for you will actually be different to what works for others. Risks tend to be individual and are greater, really, with much longer duration of use and in much older women. So during the menopause transition, when we're using it for symptoms, it's very safe for the majority of women, but it's always important to have an individual discussion with your doctor. There's a lot of sort of propaganda on social media, and I think it's really important for me to emphasize here that don't take HRT because you think it's going to prevent you ever getting a disease in the longer term. You should be taking HRT to help with your menopause symptoms, to help you get back on track if you're struggling with symptoms, so that you can use the lifestyle approaches that are going to help you really have a healthy midlife and beyond. So that's the reason to take it. But, it's important also to be aware that not everyone can take HRT. Some women try it and don't get on well with it. Some women aren't able to take it, and some women choose not to have it. And so it's important to be aware that there are other non-hormone medications, prescription medications, that can be helpful for menopause symptoms, both in terms of sweat, sleep, mood, anxiety, and bladder problems. And the choice of treatment will depend on what your specific symptoms are, because there are lots of different non-hormone medications that can be used. Vaginal estrogen can be used extremely safely for vaginal symptoms associated with menopause, and that is pretty much safe across the board for the majority of women, even women who have contraindications to full-blown sort of systemic HRT preparations. Testosterone can be used to help with libido, but testosterone levels don't actually significantly drop for most women in the menopause transition. It does drop with surgical menopause for women who've had their ovaries removed, but it's not indicated for every single woman. And again, at the moment, it's being a little bit oversold, often by people who are brand selling products on social media. And it's important to be aware, because it's quite exciting, that there is a new novel non-hormone treatment that is actually now licensed in the United States. It's not licensed in the UK, but we are really hoping that it's going to be licensed in the UK. And it's a first-in-class, brand new novel treatment for menopause vasomotor symptoms, so the hot sweats, flushes and flashes, and it seems to help with sleep and mood, and even possibly fatigue and weight management in the studies, the results suggest. So there's a couple of preparations. The one that's actually now licensed in America is called fezolinetant, and that's exciting because it may well become available in the UK. And it's great for women to have options. This would always be a second line treatment for women women who can't have or can't take HRT for menopause symptoms, but it's really important for those women who can't to have options. So I think that's really exciting and promising going forward. So, I'm not going to talk much longer. To summarize what I've said, menopause is a natural hormone transition, and which it affects every woman differently. So understanding your own health, your own menopause, other aspects that might impact on symptoms in midlife is really important, and it can help you facilitate purposeful choices. Lifestyle is very underestimated as a strategy to help menopause symptoms, and lifestyle approaches, when they're optimized, can help with your long-term well-being and health. HRT is the first-line prescription medication for menopause, and actually for most women, even those who need HRT, symptoms do tend to settle down over time for most women. And with the right knowledge, menopause actually can be an empowering time of life for women today. So I want to finish on an uplifting note and hand over to Christine to talk about some more nuanced thyroid aspects of the menopause transition. And I've written a book about menopause, just on the last slide, just to share that. And I don't know how to stop it.
I think you have stopped sharing, actually.
Oh, good.
As far as I can see.
That's good then. I can still see my slides for some reason, but I'll get rid of them.
Can you see mine?
Oh, I can, yes. Yeah.
And that's full screen now, yeah?
Yeah.
Okay, so hello. So I'm Christine Boorhout, and I'm going to talk a little bit more about thyroid, not too long, because I think the main purpose of this is for you to be able to ask questions. Why isn't this moving? Just gonna stop sharing and start it again.
There should be something on your laptop to scroll to the right hand side, which might help you to transit your slides.
Somehow it isn't there. Yes. Okay. So as an overview of what I'll be talking about is initially the overlap between symptoms of menopause and thyroid disease. And Anise has already touched on this a little bit because many of the symptoms of both menopause and thyroid disease are actually quite non-specific. How should we interpret thyroid function tests through the lifespan and then managing both hypo and hyperthyroidism during menopause? So this here is an overview of what typical symptoms of hyperthyroidism would be. And what I've done with these red circles here is highlight a number of symptoms that would be very similar for both patients with hyperthyroidism and with menopause. So it can be really quite difficult to distinguish between them. So if you're perimenopausal, it can be quite difficult to say these symptoms are due to thyroid disease or to the menopause. And indeed, in the NICE guidelines, a warning is given that often thyroid disease can be missed in perimenopausal women. Similarly, if you look at the symptoms of hypothyroidism, things such as dry hair, having a puffy face, feeling fatigued and a bit low in mood, getting forgetful and muscle aches, again, can be very similar for patients who have hypothyroidism as well as women who are becoming menopausal. And of course, it can be quite difficult based on symptoms alone to diagnose thyroid disease. So this has been well documented. This is a study that's now more than 23 years old, where 25,000 people attended a health fair in Colorado. And everyone was given a questionnaire to ask about typical symptoms of hypothyroidism. And you can see that for up to 3 symptoms of typical symptoms of hypothyroidism, there was actually no difference between patients who had normal thyroid function, which is these white bars, people who had a mildly abnormal thyroid function test, and then people who were frankly hypothyroid. So for up to 3 symptoms, this was no different. And I'm sure even if I was asked to fill in a questionnaire, it would be relatively easy for me to tick 3 of these symptoms. So it can be difficult based on symptoms alone to diagnose these diseases. And that's been further highlighted by this more recent study, where again, people were given a questionnaire, people with hypothyroidism, 140 patients, and then control patients were given a typical questionnaire of thyroid symptoms. So this was based on self-reporting, 13 typical symptoms of hypothyroidism. And again, for up to 3 symptoms, there really was no difference between cases and controls. And it was only when the symptoms became more pronounced that it was more easy to identify those patients with thyroid disease compared with healthy controls. And what this on the right here, I won't dwell on the details of this, but essentially what they developed in this study was a symptom score. And what this indicates here is that based on symptoms alone, the prediction of the presence of thyroid disease really was quite poor. And this only from 3 or more symptoms became a reliable tool. And then similarly, this is a study looking at patients who have very mildly abnormal thyroid function. So their circulating thyroid hormone levels were still normal, but their serum TSH, which is the marker of thyroid status, was slightly raised. You can see this is a large number of patients, nearly 10,000 Western European participants with a mean age of about 45 years. And essentially what these plots here indicate is again that there was no difference in patients who had subclinical hypothyroidism compared with controls, again indicating that based on symptoms alone and the use of a health-related questionnaire didn't really help us. So most of these patients had a serum TSH that was mildly raised, and then only a small minority had a TSH that was significantly raised. But again, illustrating that symptoms alone are not a very reliable tool to diagnose this. A further issue then is that as patients get older, their symptoms tend to be less pronounced and become more vague. So this here was looking at 121 subjects. The blue bars are patients who are aged less than 55, and the red bars are older patients. And you can see that the symptom score for these typical symptoms here of thyroid disease was significantly lower in older patients when compared with younger patients. So not only are symptoms very similar, they often get blunted as patients get older. And similarly, this was a study that we performed in Birmingham, looking at a large number, more than 3,000 patients who actually had an overactive thyroid gland. And we looked at the effect of age on symptoms. And again, all patients who come to our clinic have in a very systematic way their symptoms of hyperthyroidism documented. So this is up to 9 typical symptoms of hyperthyroidism. And you can see, so the lilac bars are those patients who are aged more than 61. So the older patients, you can see that more than 50% of them, even though they had biochemical evidence of hyperthyroidism, that their symptom score was really quite low. So many of them were asymptomatic or only had up to 2 symptoms. So again, indicating that with age, these symptoms become much more blunted. So how do we interpret thyroid function tests then? So when we consider that a patient may have thyroid disease, the first test we do is measuring a serum TSH. So this is your best marker of thyroid status, and that is the hormone of the pituitary gland, which is the conductor of the endocrine orchestra. We then generally will also measure a serum free T4 and occasionally a serum free T3, and often antibodies are also measured, certainly when we're looking at hypothyroidism. So we need to be aware that there are differences in TSH reference ranges. So like I said, TSH is this best marker of thyroid status. So, but these reference ranges vary by age, gender and race, and not all hospitals have these specific reference ranges available to them. But also what a further thing we need to be aware of is that many drugs will interact with thyroid function, and therefore there can be effects of drugs on thyroid function. And when someone is acutely ill, again, their thyroid function may be affected. So generally, the advice that we give to healthcare practitioners is that we shouldn't measure a single serum TSH in order to make a judgment as to whether the patient has thyroid disease or not. Often it is required that this abnormal serum TSH, so your marker of abnormal thyroid function, is present over a period of about 3 months. Because if you're acutely ill, then your thyroid function may be abnormal, and it may be that when we measure it after 3 months, it normalizes. And you can see that is illustrated here by this study. So this is looking at nearly 350,000 patients who had a serum TSH measured at baseline and then had a repeat serum TSH 5 years later. And you can see that for those patients where the serum TSH was above the reference range, so those patients who have very mild hypothyroidism, or where it really was quite frankly above the reference range, that quite a significant proportion of them actually normalized their thyroid function. So for those who had a very mild TSH, you can see that when this was rechecked after 5 years, and this is without giving the patients any treatment, that their serum TSH actually normalized. So that is why most guidelines will say don't act on a single TSH measurement. And this is here to illustrate how serum TSH reference ranges shift with age. So these are based on large databases from the United States. It's called the NHANES study that studied patients' dietary requirements and then a number of routine blood tests. And you can see, so this is the normal curve of TSH. So the normal reference range for on most assays for TSH is between 0.5 and 4.7. And this is the curve that the population would generally follow, a younger population. But you can see that with age, this curve shifts to the right. So therefore, if you take a cutoff here of serum TSH, the proportion of patients who would be considered to have abnormal thyroid function is significantly higher in older patients. And this is actually a physiological phenomenon, indicating that the higher TSH is probably normal physiology and not evidence of abnormal thyroid function. And many guidelines now recommend that certainly for patients aged over 80, that we shift this upper limit, which is generally about 4.5 of TSH, that we shift that to 7. So again, a further consideration to take into account. And then looking at the other side of the spectrum, so this is where serum TSH would be low, and that may be an indication that the patient actually has an overactive thyroid gland. Again, this can be very confusing because patients who are ill, so we call this patients who have abnormal thyroid function, but have a non-thyroidal illness, their thyroid function tests can be very similar to patients who actually have a mildly overactive thyroid gland. You can see that TSH will be low in both conditions. And again, the circulating thyroid hormones may be abnormal in patients who have non-thyroidal illness without there being thyroid disease present. And if we had this measurement here of a reverse T3 available to us, we might be able to distinguish more readily between these two conditions, but this is not a laboratory test that's routinely available. So what do NICE guidelines tell us in order to diagnose thyroid disease? So we should do a thyroid function test where there is a clinical suspicion that the patient may have thyroid disease, although as I've already illustrated, a single symptom often is not indicative. Anis has already alluded that often, so many thyroid diseases, or most thyroid diseases that we see in the UK, are autoimmune, so caused by antibodies to the thyroid gland. And often autoimmune diseases go together, such as premature ovarian insufficiency, but also other autoimmune diseases. So they recommend that in patients who have type 1 diabetes or other autoimmune diseases, that you would have a lower threshold for measuring thyroid function test. Patients who have resistant depression or unexplained anxiety, but there's a very specific warning in the NICE guidelines that symptoms of the menopause can be very confusing when diagnosing thyroid disease. And as I've already illustrated, this should be avoided in patients who are acutely ill. And then what I found was a number of studies that have specifically looked at menopausal women and then how this links with thyroid symptoms. So this is these were studies performed in Japan. This is 853 women who were aged 35 to 59 years. And they were all asked or assessed by using a simplified menopause index score, as well as their menopause status. So these are typical menopausal symptoms that we were all aware of. And unsurprisingly, you can see that as patients went from being pre-menopausal to perimenopausal, and then following the menopause and many years later after the menopause, that these symptoms initially increase. And as Anise already said, be assured the symptoms will subsequently decrease, as was clearly illustrated here. But then specifically looking at how this interacted with symptoms of hypothyroidism, you can see that there actually was very little difference in patients who had additional thyroid disease in addition to menopausal symptoms. So none of these symptoms other than headaches, nausea, and tiredness were very specific for identifying patients with hypothyroidism. So again, indicating that this really can be quite a difficult scenario to distinguish. How should we then manage patients who are on hormone replacement therapy, or patients who are going on to hormone replacement therapy when they're taking levothyroxine treatment? So we know very well that when you take estrogen, that this will affect the binding proteins. So thyroid hormones circulate in the blood bound to proteins. And we know very well from situations like pregnancy, but also people who take estrogens, that actually the binding protein to which thyroid hormones bind will increase by giving estrogen. So generally the recommendation is that when a patient is on levothyroxine and they start HRT, that we recheck their thyroid function test. What this study here looked at was actually the effect of various forms of either estrogen or progesterone and how this affected thyroid function. And actually, there was not that much difference with regards to thyroid function. However, the current recommendation still is, because we know that physiologically there will be changes to the binding proteins, and therefore it may be that the dose of levothyroxine needs to be adjusted. So when patients start HRT, that we recheck thyroid function test, certainly 3 months into the HRT, to make sure that they're still on adequate replacement. And obviously, if patients don't feel well following starting HRT, then that should be a further impetus to do thyroid function test. And then going back to this study of the 800 and odd Japanese women who had symptoms of hypothyroidism, again, when they looked at those patients who actually had an overactive thyroid gland, who had Graves' disease, again, there was very little correlation, hardly any of these p-values here, or none of these p-values were very significant with regards to how easy it was to distinguish between patients who had menopausal symptoms and those patients who had hypothyroidism. There was a positive correlation with breathlessness and palpitation, but again, what this study concluded was that symptoms of thyroid function abnormalities and menopause are very similar, and therefore it can be really quite difficult to distinguish. So just as a summary, I hope I've convinced you that symptoms of thyroid disease and menopause are very similar, and I'm not sure that that necessarily helps us very much in distinguishing the two. As we get older, we have fewer symptoms of thyroid disease, but it's really quite difficult to diagnose the presence of thyroid disease based on a single symptom. Interpretation of thyroid function tests needs to take a number of factors into account, including the patient's age, their gender, but also a number of other factors that typically will affect thyroid function. Be aware that even if a thyroid function test is mildly abnormal, very often, as we illustrated by that very large study, often they normalize spontaneously. But certainly in patients who are starting HRT and who are taking levothyroxine, those adjustments may be required. So I will leave it there. I will stop sharing, and I'm happy to help answer any questions that you may have.
Thank you, Christine, and thank you, Anise, for that comprehensive overview of both a holistic approach to menopause care and a detailed look at thyroid conditions during this time of a woman's life. We've had lots and lots of questions, which is great. Anise, I wondered if I could come to you first with some general questions about when we decide that HRT is appropriate, what benefit does this confer in terms of being protective from dementia, the risk of developing dementia, and in terms of benefits for cardiovascular health? So we have some women who have explained that In the past, their GP was perhaps dismissive of HRT and highlighted the risks, but now the tide has turned and women are thinking HRT might be good for their current symptoms, but also of benefit in terms of their long-term health.
Okay, so in terms of all of the international and national guidance on indications for menopause hormone therapy or HRT, the main indication in the context of natural menopause for HRT is to treat menopause symptoms first and foremost. For as long as that woman needs treatment for those symptoms. So there is no time limit on HRT. And of course, managing those symptoms allow women to, make sure that they can stay in the workplace, they can have their care roles, they can do all of the things that they need to do, and they can focus on lifestyle approaches. In terms of disease prevention, which is, I think, what you've alluded to, so cardiovascular disease, dementia, there is no consensus that hormone replacement therapy has any significant impact either way on prevention of dementia. So there are a number of different studies and there are meta-analyses that have been looked at, and essentially what we found so far is there is a null effect. So some studies actually suggest HRT can increase the risk of dementia. Some studies suggest it reduces it. Others say, there's no difference. And it's difficult because the groups that are studied are quite heterogeneous. So different groups of women, different treatments. There's some interesting work that's being undertaken on neuroimaging to see, the brain changes that occur in the short term with hormone therapies. That doesn't necessarily mean, even if you see some brain changes over a few months, that that's going to prevent disease in the long term. So there is no international agreement that HRT should be used to prevent dementia at all in terms of international guidance, any of the international menopause societies. Osteoporosis, once again, HRT is not recommended to prevent osteoporosis in natural menopause because there are risks with HRT in the long term. And if you're going to use HRT to prevent osteoporosis, you then have to commit to using it lifelong. So we wouldn't be using that in people who have healthy bones, who don't have any indications for HRT treatment for osteoporosis. If somebody has established osteoporosis at a younger age, and I'll just come to POI separately because you've asked a huge question, so it all is gone, so I'm trying to cover it all. In natural menopause, we wouldn't be using HRT to prevent osteoporosis, but we do sometimes, we use it in premature ovarian insufficiency, which I'll come to, and we use it in some women who are going through the menopause transition to delay the need for other osteoporosis interventions if there is established osteoporosis or low trauma fractures, etc., during that phase. So that's it's not the same for women who have established osteoporosis as for those who are just worried about osteoporosis but don't have it. And for cardiovascular disease in younger women, so again, this is going back to the POI, which is premature ovarian insufficiency, women who have a very early menopause under the age of 40, we do recommend that HRT is used to protect bones for younger women and to protect the cardiovascular system. And in terms of the cardiovascular system, it's a bit complicated. We don't recommend HRT is started after the age of 60, and we describe something as the timing hypothesis, which is if you take HRT before you have any blood vessel disease, it's protective. If you take HRT once you have established blood vessel disease, which is more common as you get older, it seems to accelerate disease. So we use this sort of, the timing hypothesis is, if you're under 60, you can have HRT safely. But the problem is if you have very high cholesterol or other health issues that are accelerating your blood vessel diseases, and we know that young women in their 20s with, cholesterol problems and other risk factors can have heart disease and blood vessel disease even when they're premenopausal, we have to just be cautious with women with lots of risk factors. So it's very nuanced. I'm trying to, describe something that's quite complicated in a short period of time, but the point is it's quite different for every woman. So the guidelines are we recommend HRT to protect women's blood vessels and bones when they're younger if they have a very early menopause, but as they get older the risks start to rise, and certainly after the age of 60 we don't recommend HRT to be started for any sort of disease prevention, and the predominant reason for taking it is to protect, you know, menopause symptoms and menopause health. I hope I've answered the question.
Yeah, no, that's great, thank you. There is a woman on the chat who is 65 and is suffering with hot flushes, and she's wondering why her GP isn't perhaps agreeable to giving her HRT to manage those specific symptoms. You did mention about the age cutoff during your answer, but if there's a woman in her mid-60s with really difficult symptoms that should respond to estrogen replacement, what do you think about that?
So there's been a lot of caution amongst GPs using HRT because of the historic research data we have showing that older women seem to come to more harm with HRT, especially the older fashioned HRTs that were used in the mega trials that were published in the early 2000s, particularly the Women's Health Initiative study. So in fact, the British Menopause Society are writing a new educational tool for doctors to try and help doctors, and I've been involved in that in terms of case scenarios. So in a woman who's 65, if she's otherwise very fit and well and has no risk factors, and she's got menopause symptoms, then there's no reason why she shouldn't have a trial of HRT. She just needs to be told that there is slightly more uncertainty, particularly about you know risks in older women and with longer term use in older women. Somebody who's 65, has she had symptoms ever since she went into natural menopause? Because if those symptoms are new, there may be other causes for, you know, vasomotor symptoms, fatigue, aches and pains. So we'd want the GP to look at if there's any other cause for symptoms. And if a GP is going to start HRT in a woman who's older, they do need to check whether or not she has any risk factors for heart disease or blood vessel diseases. You know, so if she's got very high blood pressure, high cholesterol, diabetes, if her weight is above target limits, they all need to be managed and addressed as well alongside HRT. So we would be using HRT to help symptoms, but we would need to use that in conjunction with protecting that woman against any other potential health risks that could potentially be, you know, problematic with HRT.
Okay, great. And then we've had a question from a woman with a diagnosis of differentiated thyroid cancer. So you may both want to comment on this, but Christine, can I ask you first? This woman is asking whether her journey through the menopause should be any different because she's received a thyroid cancer diagnosis previously.
Yes, I'm assuming that the thyroid cancer was treated with a total thyroidectomy, potentially with or without radioiodine, and that therefore the patient is likely to be on levothyroxine. So, like I said, with menopause, especially when HRT is started, there may be changes, and therefore a dose of levothyroxine may need to be adjusted. The target range of the levothyroxine will very much depend on the aggressiveness of this cancer and the sort of the risk score that's been allocated to this. But I think other than that, so if HRT is started, then yes, we may have to adjust the dose of levothyroxine. Is there a particular risk of HRT? If that's the question, and I don't know, but is there a risk of that making the thyroid cancer come back or worse? So we know that there are estrogen receptors in thyroid follicular cells, and there is some patchy evidence that estrogen may drive thyroid cancer a little bit. That evidence is not clear, and it's certainly not well documented that women who go on HRT during menopause when they've had thyroid cancer, that they are at significantly increased risk, and it's certainly not something that we would say is a contraindication to starting HRT. But I do hope that I've answered what this particular participant was asking.
Okay, and we've had some questions which you have said about women who start estrogen, we need to recheck their thyroid function once they're established on estrogen therapy. But we've had some questions about different routes of estrogen hormone replacement. So women who are receiving transdermal estrogen or vaginal estrogen only, do they need their thyroid function reassessed as well as those taking oral estrogen?
I think the evidence when you look at this, the evidence isn't actually that clear, but I think just local application of vaginal estrogen, it's unlikely, I think, that there is significant amounts absorbed there to affect it. I think with transdermal preparations, and Annelies may want to come in here because she probably knows all the preparations better than I do, there may actually be some absorption of estrogen that may affect it. I think if a patient is on levothyroxine and was fine and suddenly starts feeling unwell, I think that's a reason to check a serum TSH and just to make sure that things are okay, because it may not be related to it, but it's a simple test to do. It's not very expensive, and often a simple adjustment can make a big difference there. But so that would be my pragmatic approach to that.
Great. And we've had some questions about supplements taken to help with health and well-being during the menopause and the impact of those on the thyroid. So Christine, I just wondered if you could comment on, we've had a query about iodine and a query about soy and what we need to think about in terms of thyroid function with supplements that contain either of those.
So I think, as ever in life, if you do these things in moderation, it's fine. Taking a little bit of iodine is fine. We are probably mildly to moderately iodine deficient in the United Kingdom. If you're a vegan, you're almost certainly a little bit iodine deficient. And therefore taking things in moderation is fine. If you take very excessive amounts of iodine and soy, then yes, this will affect your thyroid function test. And there's certainly been case reports now, often, certainly with regards to soy, these are people who take huge amounts. And, you know, I think it's sort of slightly common sense that as long as you do it in moderation, it's fine. Many of the supplements are fine, contain a lot of good things. And as Annelies has indicated, you know, many of those general well-being supplements help us feel better. You know, that's why they're there, but I wouldn't overdo it.
Perfect. Annelies, can I come back to you about supplements? So we've had a number of people on the chat commenting about vitamin D, and we know how, you know, we're all big fans of that in endocrinology, but a number of people are asking, is there a specific dose you would recommend? You know, should we be considering taking it all year round, or any particular preparation you would recommend? And can you come to harm from taking too much?
So I'll start with the last one first. You can come to harm from taking too much. It's a bit like Christine says, if you go for mega doses and you're on those for a long time, you can. It's quite hard to overdose on vitamin D. You'd have to try very, very hard. A nice study in the Royal College of Physicians journal, actually, by one of your colleagues in Newcastle a couple of years ago, showed very nicely that the safe range for vitamin D in general that you're unlikely to overdose from is somewhere between 1,000 and 4,000 international units a day. So 1,000 international units is 25 micrograms, and we're usually talking about vitamin D3 because that's the one that you can usually get orally in the UK. And so somewhere between those two doses, you are very unlikely to have too much vitamin D. The problem is we're all slightly different in the exposure that we get from sunlight, for example, how much we might get from our diet, although there's very little vitamin D in normal diets if we're not eating foods that are fortified with vitamin D. So generally for bones, we say 1,000 international units is a good amount for bones, but I think like in Adcal D3, there's less than that in the Adcal D3 supplement's got quite a lot of calcium in it. So there isn't really this dose is for everybody. The government guidance is much lower. It's 5 micrograms, which is a tiny dose, 200 international units. But that's not specifically in terms of protecting your bones. So when we're looking at bones, we're looking at really generally around 1,000 international units a day. So, I mean, that's definitely very safe, and you can get it over the counter, but you're unlikely, unless you have established osteoporosis, to be able to get that on a prescription from your doctor.
Okay, great. And Annelies, can I ask you, first of all, we have a number of patients asking about weight loss when they're transitioning through the menopause and they have a thyroid condition. Is it harder for women to lose weight if they want to in that scenario?
It's really difficult for anyone to lose weight in our modern society. We live in what we call obesogenic environment today. So most people find it very easy to gain weight and very difficult to lose any sort of weight. Weight loss requires significant calorie deficits, which are difficult to achieve for all of us. And modern diets tend to have a lot more even inadvertent processed foods, which tend to help us gain weight quite easily. When it comes to specifically thyroid, I mean, Christine might want to say something. What I would want is to make sure that that woman's thyroid function is optimized. So if you're on thyroxine medication or thyroid replacement medication, and you're going through the menopause transition, and perhaps you've gone on some new treatment, and you know your TSH may have risen, you may not be on an optimal dose of levothyroxine. Christine might want to talk about optimal TSH in people on treatment. You talked a little bit, Christine, about normal ranges for healthy populations, but we would want generally to have a lower level of TSH as a target for people on treatment, which Christine can talk about. But once you've got an optimal TSH, then it shouldn't be harder than anyone else to lose weight, but it is hard for everybody to lose weight. And actually, I saw a lady in my clinic this morning who said she was going to join, who had to have a few little tweaks in her thyroxine medication. She'd been struggling since 2015 when she went on to thyroxine, but she'd never really probably had her dosing optimized. And she came back today, she's on HRT and levothyroxine, and her dose is optimized. And she said, you know, I felt better than I felt for 8 years. I feel so good. And she was very grateful. So I said, oh, you know, join the webinar tonight. But I don't know whether she's on. She might make a comment. But yeah, so I'll hand over to Christine to talk about optimizing thyroid function on replacement therapy.
Yeah, so the first thing to note is that everybody has their own set point for thyroid function, and that's genetically determined. So Catherine's will be different from Anissa's, will be different from mine. And often what we don't have is we don't know what the patient's thyroid function was before they became ill, because we might then know what's optimal for them. I've illustrated that it also shifts with age. There's a physiological shift. I think personally that many people feel better when a serum TSH is around 2. And certainly what NICE guidelines allow, and what I often do is, like what Anise just described, is a little bit of tinkering with the dose of levothyroxine, because I think what we're all trying to say here is that this is all about personalized decision-making for patients. There is no one-fits-all rule. That's not how it works. And it is, how can I make this patient feel the best possible? And as long as that serum TSH doesn't go significantly below the reference range, because that is when you run into trouble, and where certainly your bone health will get into significant trouble, where your cardiovascular system will get into significant trouble. Adjusting that levothyroxine for that particular patient, I think is a good thing, and many patients do indeed feel significantly better. Just targeting, you know, what is probably their normal set point, and it's very difficult to. It may be that in the future we will have some prediction tools that say this patient has this set point, this patient has this set point, but that's certainly not routinely available yet.
Okay, and on the topic of thyroid disease, we have someone on the chat asking about the peak incidence of Graves' disease and other autoimmune thyroid diseases. And when we look at when that tends to happen in women, is there a relationship with female hormones and autoimmune thyroid disease? Is it clear cut or not?
So the peak incidence of Graves' disease is between 30 and 60. It's a lot more common in women than in men, as most autoimmune diseases are. Now, a lot of those autoimmune diseases occur at different times and are sort of not linked to reproductive hormones. We don't know what determines whether a patient, well, we know that about 80% of what determines if you're going to get Graves' disease is your genetic predisposition. So 80% of this is genetically determined, which is why 50% of patients with Graves' disease report that they have a family history. 20% are environmental factors, and we know that reproductive hormones do play a role in that, because we certainly get changes to the way Graves' disease behaves when there are changes in reproductive hormones. So Graves' disease gets better in pregnancy and flares up after delivery. So that indicates that reproductive hormones play a role. How clear-cut that relationship is, we don't know. It is not that people who become menopausal, suddenly we get this shooting, you know, this peak incidence of Graves' disease, because it is so multifactorial, and still 80% of it is depending on what the genetic makeup of that person is.
Okay, thank you. Anise, can I come back to you to ask about patients who are suddenly plunged into a surgical menopause? We have some women who have experienced really debilitating symptoms and all of a sudden are trying their best to deal with this. And of course, our individual situations will be different, but have you got any particular recommendations about women who experience this type of menopause journey and what might help them?
So you're not talking about in the context of thyroid disease, just in general?
No, just in general.
Okay, so I mean, it does, a sudden surgical menopause, it does tend to be associated with quite a severe set of symptoms, and we would normally, in most situations, and it obviously depends on why that woman's been plunged into surgical menopause, we would generally want to give them hormone therapy. But it depends on many different factors. So if you've been very ill and you've had to have a hysterectomy and you've been anemic and bleeding, or you've had a cancer diagnosis, all of those other things that have led to that hysterectomy can factor in to the symptoms that woman will experience post-operatively. Also, whether she's had a vaginal hysterectomy or whether she's had a total abdominal hysterectomy, you know, that the actual procedure itself might have a different impact on surgical recovery. If a woman is plunged into a surgical menopause from a cancer diagnosis, you know, she may not be suitable for hormone therapy, and that obviously can be really tough if she's gone from being premenopausal to being postmenopausal and can't be given any hormones. That's really difficult, and hopefully her cancer team will be able to support her with all the tools that will provide her with alternatives to HRT and strategies to help with symptoms. In women who've had a total hysterectomy or a hysterectomy for and a total hysterectomy for endometriosis, for example, we would generally be giving estrogen replacement and may well give progesterone replacement as well, because of the endometriosis, for up to a year, possibly longer, after the hysterectomy. When you've had your ovaries removed, you lose your ovarian source of testosterone. So there does seem to be greater benefit of testosterone therapy in women who've had a total hysterectomy with their ovaries removed. So it's about tailoring the treatment to benefit that woman's symptoms. It's going in the early stage after surgery. It's about recovering from the surgery and why the surgery was done, whether there's anemia, treating all those other things, because other things can be going on, cancer diagnosis, other things in life, anemia, thyroid problems, putting that woman on treatment that helps with her symptoms. So it can take time. Surgeons often, gynecologists often put women on a standard HRT regimen, and that will need to be tweaked, a little bit like when you start thyroxine, the dose will need to be tweaked. So I think optimizing treatment for an individual woman and all the things around what's happened in that surgical diagnosis is important. And there isn't a one size fits all, really.
Okay, great. Thank you. We're just after 7 o'clock now, so we probably need to begin to draw things to a close. I just wondered, Christine, if I could ask you quickly about a question that's popped up about selenium. And we know its benefit in patients with thyroid eye disease, but in general, should we be considering taking selenium if we have a thyroid problem, and particularly if we're menopausal?
Okay, so the evidence around selenium is mainly in patients with thyroid eye disease. The trials that have been done have shown that in patients who have raised antibodies to the thyroid gland, selenium will actually bring those antibody levels down. The trials have not shown that taking selenium gives improvement in thyroid function. Again, I think if you feel better on selenium, do I have a problem with you taking that? No. I would suggest, however, here's a tip. Don't go and buy expensive selenium in Holland and Barrett. Just go and buy a packet of Brazil nuts in Asda, and it's much cheaper and it's full of selenium. But so I don't think there's a danger in taking selenium. I don't think there's clear evidence other than in patients with thyroid eye disease that it particularly helps thyroid symptoms. It may bring TPO antibodies down. That does not appear to be relating to an improvement in patient symptoms.
Okay, thank you. And thank you both for sharing so much information this evening. I'm sure everyone that's joined will have found it very useful. I'll hand back now to Julia to conclude the webinar. Thank you.
So thank you, everybody. Thank you to our excellent speakers, Anise and Christine, for such interesting and thorough presentations. And a special thank you to Catherine for doing such an excellent job of sifting through the huge number of questions. We had about 140 questions and putting to the speakers with such skill. The questions they raised they covered such a lot of ground. So thank you to everybody who contributed to what we all learnt by asking them. My particular take home was the fact that not one size does not fit all, and the importance of tailoring treatment and working with doctors and looking after your own general health and well-being to optimize how we all feel with respect to menopause and thyroid, of course. If you joined late or there are bits that you'd like to go back to and watch again, we'll be adding a recording of the session to our website, and it will be on YouTube in a day or so. So please look out for that. And just a plug for the BTF, we're a small charity and we rely on fundraising and donations to continue our work. So if you're able to support us and to help us continue to offer free events like this, please do consider joining the BTF as a member or making a donation, however small. It would be much appreciated. So once again, thank you to our wonderful speakers and to our chair. We know how busy you all are, and we really are grateful that you found the time to spend tonight running this session for us. And finally, a big thank you to all of you who joined the webinar and asked such great questions. Please stay in touch with the BTF, and we look forward to seeing you at future events. Thank you.